brings to the practice of cancer care as a human social endeavour. Because as we all know, cancer care at the end of the day is really all about people. And we have two very distinguished speakers to give voice to the people aspect of comprehensive cancer care, which we know extends beyond the individual patient and their biology to encompass the entire support network. So firstly, let me introduce Dr. Breffni Hannon. Breffni is a graduate of University College Cork, and after completing her specialist palliative care training in Ireland, she moved to Toronto to complete a clinical research fellowship at the Princess Margaret Cancer Centre. And she now leads the palliative care programme at the Princess Margaret and is the Rose Chair in Palliative Medicine and Supportive Care at the University of Toronto. And her research interests include early integrated palliative care for patients with advanced cancer and interventions to assess and respond to caregiver distress. We're also very fortunate here in Cork to not only have Breffni share some of her research from Toronto with us today, but we have great ongoing collaborative research occurring between Marymount Hospice in Cork and Breffni's team in the Princess Margaret, designing and translating international level research to reach the bedsides of HSE South-West patients. So we're delighted to welcome her today. Now, her talk today will give voice to the state of the art and the science of supportive interventions for caregivers in this very challenging context of metastatic cancer. And I think I speak for everyone when we say we're really looking forward to hearing about such interventions, because we recognise that while informal caregiving is critical to good cancer outcomes, unfortunately the role is also associated with substantial health and social risks, which are largely underserved in existing cancer care systems. And coupled with the knowledge that most patients we see have most of their cancer care delivered by family caregivers, and that most of us ourselves would be informal caregivers in our lifetimes too, there really is a public health imperative to design and test health and social care solutions for what is becoming a near universal role. Then our second speaker is probably well known to everybody here today. It's Dr. Andy Phillips, and we're delighted he's been able to find time in a very busy schedule to join us today. A self-declared Welsh Kiwi, Dr. Andy Phillips came Cork area to be the Regional Executive Officer, HSE South-West, working in clinical, operational and strategic executive leadership roles in healthcare in the UK NHS, Australia and New Zealand for the past 37 years, so a lot of experience. Andy maintains his clinical qualification as consultant clinical scientist. Now, since 2009, Andy has been leading large-scale health system transformation with a passion for delivering value for money through integrating health and social care. And he's practiced co-creating health and relationship-centred healthcare for over 20 years, with recent work leading kindness and compassion in healthcare. And Andy took up his role as REO in HSE South-West on the 1st of March 2024. His talk is entitled Integrating Health and Social Care to Optimise Cancer Outcomes. And I suppose with this talk, we may get the opportunity to think about and consider system design and integration. And this is a brief, I think, that bears a heavy mantle of generating the right conditions for compassionate and high quality care in complex circumstances, that honours an individualised approach, but somewhat then paradoxically needs to be delivered at scale. So it's a pretty big brief. So I hope everyone has a cup of coffee or their lunch, sit back and listen to these very two distinguished speakers. Pop your thoughts into the chat function along the way. And I hope I do them justice at the end in terms of representing you and your thoughts and your questions. I think the ask now is that everyone mutes their microphones to allow the speakers their time in an uninterrupted way. And I will talk to you after the talks, which will run back to back. And we have about, I'd say, 15 minutes at the end, kind of look at your comments, your queries, your questions. So I hope you all enjoy. And I'm going to hand you over firstly to Dr. Breffni Hannon. Thanks, Breffni.
Thanks, Fiona. I hope everyone can hear me okay. Greetings from Toronto. I was going to say good morning, but of course it's good afternoon for you guys. Morning here in Toronto. So thank you so much for the opportunity to come and talk to this incredible group, and really looking forward to Andy's talk. This afternoon, I'm going to be chatting to you about caregiver interventions and supporting carers around metastatic disease. So, while I don't have any specific conflicts of interest to declare, because unfortunately, caregiver research is not something that is typically commercially interesting at the present time, I do have to acknowledge that some of the work I'm going to be presenting today has been supported by grants from the University Health Network, Grand Challenge Touch, Human Touch in Cancer, and the Mount Sinai Hospital University Health Network Innovation Fund. And I'm also very generously supported by the Rose Family Chair at the University of Toronto. So you're lucky that we only have 20 minutes because I could bore you all to tears for the whole afternoon talking about caregivers, which has become a real passion area of mine when it comes to research and also clinical care. So I'm going to try and confine my enthusiasm to the following kind of outlines. So I'm going to define what I mean by caregivers first, because I know often there's a little bit of ambiguity around that. I'm going to try and characterize why this is an important issue for us as healthcare providers who look after patients with cancer. There have been many interventions to support caregivers. I don't have time to talk about them all, but I'm going to discuss some of them. And I'm going to describe a study that our team has recently completed. I'm going to highlight some of the learnings from that and talk about where we hope to go next. So there are many different definitions of caregivers, but I like this one, which defines them as relatives or friends who provide unpaid care for patients, assisting with physically, emotionally, and socially demanding tasks. I like it because it doesn't limit it to immediate family, and it recognizes that caregiving can be provided by a range of folks, not necessarily your biological family, but can be your chosen family, friends, neighbors, loved ones. And it is estimated that at least 1 in 10 adults in the US and Europe are family caregivers, but it is also acknowledged that this is likely a conservative estimate because there are many, many, many people who provide the role of what we would consider a caregiver, but don't call themselves that because they're often doing a paid job at the same time. Cancer is among the most common diagnoses requiring care support. And when we think about caregivers of patients with cancer, I always think it's important to consider where cancer kind of comes in terms of somebody's life stage. What I mean by that is the average age that somebody gets diagnosed with cancer right now is in their mid-60s. So when you think about where an adult in their mid-60s is in terms of their life stage, they're coming towards retirement, planning the next phase of their life. And who the caregivers typically are in this scenario, it's often the spouse of a patient, it could be a sibling, it could be an adult child. And with adult children in particular, if you sort of figure out the sums on this, if you're in your mid-60s as a patient, maybe your adult child is in their 30s or 40s, thinking about the life stage that individual is at. They have often their own family. They're at their own kind of career stage where they're, trying to advance their careers. They're dealing with maybe a mortgage, financial concerns. And so taking on a caregiver role that they are very ill prepared for is a huge life change, which I think is why it's so important for us to consider the role of caregivers as we do. And so why should we care about this topic? Well, the majority of cancer care now occurs in outpatient settings. So you get a cancer diagnosis, all of a sudden you get a raft of appointments to come for CT scans and x-rays and appointments with your surgical oncologist, your medical oncologist, your radiation oncologist, maybe your palliative care team. And they all have to be slotted into everything else that you're doing in your life as a caregiver. Certainly here in Canada, and I am pretty sure in Ireland also, there really is a crisis of healthcare human resources, meaning we have shortages of nurses, of formal caregiving supports, community teams. So there is much less formal support in the community for patients with cancer, and more caregivers are being tasked with managing complex care in a fragmented health system. Just like you in Ireland, there are big discrepancies between care that's provided in hospitals and care that's provided in the community, different budget, different organizational structures, and not necessarily very integrated with one another. We know that thankfully patients with cancer now live longer, which is fantastic. But of course, that also adds to the duration, the burden, if you want to call it, of caregiving. It is not something that is typically a short endeavor for most patients and their families, but something that can go on for years, and often with increasing morbidity as patients live longer, but with more complications of their cancer and its treatment. And while it's almost impossible to put a monetary value on the care provided by informal caregivers, I found this statistic from the US where it is estimated that care provided by informal caregivers, this is an enormous amount of money, is estimated at more than 475 billion with a B dollars per year, which is more than a quarter of the total annual healthcare spend in the US, which I think, having a very cursory knowledge of the US healthcare system, is enormous. And it just goes to show how significant this issue is. So there has increasingly over the past, I would say, 5 to 10 years, been a call to recognize the importance of caregivers, not just as partners in care, so recognizing that patients don't typically exist in a vacuum, but they exist as part of a larger ecosystem that includes their family, friends, and their caregivers. But also that we might be better spent considering caregivers almost as patients in their own right, with their own unique challenges and concerns and health issues. And there is concerning evidence that the emotional well-being of caregivers is significantly worse than both the general population and the patients they care for. We'll think about that for a second, because when we see as palliative care providers, when we see patients, we're very fixated on their physical well-being, on their emotional well-being, on their spiritual well-being. We spend a lot of time assessing that. The person who's also in the room at that visit, the caregiver, is probably struggling more emotionally than the patient that you're giving all of this time and attention to. And here are some statistics to support that. So anxiety has been reported in up to 40% of caregivers versus 28% of patients. Depression in up to 35% of caregivers versus 23% of patients. And these are estimates based on, all cancers, all stages. We know that it is probably higher again in certain cancer groups, particularly things like malignant brain tumors or GI cancers, cancers where there is already upfront a high burden of caregiving. And again, these are just estimates. Others have reported even higher levels of anxiety and depression. I've lowballed them here deliberately, but you can see they're still pretty significant and significantly higher than that we see for patients. So what do we know about what caregivers need? Well, actually not that much, unfortunately. My colleagues at Princess Margaret a number of years back did focus groups with bereaved and current caregivers of patients with advanced cancer and found a desire for support across 3 broad domains. Number 1, around decision-making or problem-solving in the face of uncertainty. When somebody gets a cancer diagnosis, we bombard them with all these decisions and choices to make, and we don't really give them any tools for how they make those decisions. It's like, make this decision now about whether you want X or Y or A or B. And that's difficult for caregivers. Information about death and dying was the second domain that caregivers felt they really needed specific support. Oftentimes we would report, I need to know what will happen in the future. Maybe my loved one doesn't want to talk about that, and I respect that, but I'm going to be the one who's going to be dealing with this when the time comes. So even if the patient doesn't want information about death or dying or are not ready to receive that information, it's something that caregivers often report that they need independently. And finally, the third domain was around their anticipated emotional distress. So right now I'm feeling very distressed, but I know that it's going to get worse. It's going to become more challenging for me. What do I need to know? How am I going to prepare myself? And what supports are available for me? And there are many, many structural and organizational barriers to supporting the unique needs of caregivers. First of all, cancer care is very much organized around the patient rather than the family unit. Secondly, we don't always offer information at the time or the place when patients and their caregivers need it. It's not a once in a lifetime opportunity. I'm going to give you information today. If you're not able or ready to receive it, I'm not going to offer it to you again. Caregivers spoke about, really wanting to be able to ask their questions at any point on the disease trajectory, not at this one single moment. And the third and probably most important barrier is this whole idea of self-silencing, or the idea that caregivers, really tend to dismiss their own needs. They recognize that the patient is a star of the show and that they shouldn't be taking up valuable time of, doctors and nurses and other healthcare providers by talking about their distress. And so there have been some interventions to support caregivers, and these can broadly be categorized into the target population that was the focus of the studies. So there have been some studies that have looked at caregivers themselves, but more often we see studies that look at caregivers and patients together, either as a dyad or a pair, or interventions that have been focused on patients, but have done a little bit of caregiver intervention on the side. And a couple of years ago, we published this meta-analysis looking at interventions to improve outcomes for caregivers of patients with advanced cancer. We found 49 distinct trials, but only 16 of which reported interventions directed specifically at caregivers. And I'm going to just talk briefly about two of those interventions because they're, from, I think, a pretty well-known group in the US who does really incredible research when it comes to early palliative care in general and has now moved a little bit more into caregiver interventions. So the first was the BMT CARE study, which was a single-center randomized controlled trial at Boston. You'll recognize some of the names on the screen grab of the title. This is from Jennifer Temmel and her group, Arish Aljawari, who's a hematologist who does a lot of early palliative care work in malignant hematology. And this was a multimodal psychosocial intervention for caregivers of patients undergoing a stem cell transplant. They recruited 100 caregivers to 6 sessions, which were focused on coping skills. And these were a combination of education and cognitive behavioral strategies tailored to the typical trajectory of a patient undergoing a stem cell transplant. They offered it in person or virtually, and they found that it was feasible. They were able to recruit more than 70% of eligible caregivers, and they did find positive outcomes. So they found better quality of life, better self-efficacy and coping, and lower burden, depression, and anxiety compared with usual care. So a positive study. Second, it was published about a year ago in the Journal of Clinical Oncology. It was called NeuroCare. It was a single-center randomized clinical trial, and it was broadly based on the intervention I just spoke to you about, the bone marrow transplant group, the same group from Boston, but including some folks who specifically look after patients with primary malignant brain tumors. And again, it was a psychological intervention for these caregivers and really tailored around the unique needs of this patient population. They recruited 120 caregivers. Again, there was 6 sessions, but differently, this one was exclusively delivered by telehealth, I think because it was partly conducted over the course of the pandemic. The primary outcome measure was at 11 weeks and was anxiety, and they found that intervention participants reported significantly lower anxiety than usual care participants. They also found lower rates of depression, as well as better self-efficacy and coping, and the depression, self-efficacy, and coping were maintained at a later time point. But there are some inherent challenges with these types of models. I think we can all agree. First of all, these are incredible studies published in high impact journals and conducted in a very rigorous way by, a top of the game research team working at an incredible academic center in the US. But they're very resource intensive. When we think about, our patients that we each look after every single day and their caregivers, it's hard to imagine how we could reproduce these types of interventions outside of an academic center and outside of a study environment, because they're very rigorous. They involve a lot of time, a lot of energy, a lot of effort on behalf of the study team, but also on behalf of caregivers. And what you find in these studies, as excellent as they are, is that there's a tendency to recruit participants from high-income, highly educated backgrounds. And while there's nothing wrong with people who come from high-income, highly educated backgrounds, they're not necessarily the people that we need to target when we're targeting caregiver interventions, because people who come from high-income, highly educated backgrounds are often able to look after themselves. They're able to access resources. They're often able to pay for extra help. They're not the neediest group when it comes to caregivers. And they certainly don't represent the needs of every single caregiver that we see. Secondly, these interventions don't target all facets of caregiving needs. You'll remember that both of these models were very much based on psychological well-being. And while that is hugely important, and I showed you some stark statistics about that earlier on, it's not everything that caregivers are dealing with. We know that they're dealing with financial issues, they're dealing with their own health issues, they're dealing with anticipatory grief for the future, many different things. And these interventions, as good as they are really looking at a very narrow focus of caregiver needs. And as I said, diverse caregiver populations are typically underrepresented. So again, many of these studies, when you look at the demographics sections of the results, you'll see that the majority of caregivers were white. And they're often spousal caregivers. So again, very important folks to look after, but not representing, a child or multi-generational caregiving challenges, or not representing diverse ethnic and racial or cultural groups who we know are already disadvantaged when it comes to healthcare access and caregiving issues. So we took all of this into mind, and a couple of years ago, we were fortunate to get some funding at our centre to conduct a pilot feasibility study of a caregiver distress assessment tool and a tailored intervention. So the purpose of this was we really wanted to kind of replicate what we do for patients. So when patients come to the palliative care clinic, they fill out their symptom screening form, their ESAS, and we use that ESAS then in the clinic to inform how we interact with the patient. So if they're scoring pain at 10, we're going to focus on their pain. If they're scoring depression at 8, we're going to focus on their depression. We're not just going to, present a very paint by numbers situation. The idea is that we're tailoring our intervention for patients based on their screening. And we wanted to do something similar for caregivers. And so we came across a measure called the Carer's Alert Thermometer, which is a 13-item Likert scale measure, which looks at a wide variety of elements of caregiver distress. And we wanted to know if caregivers would fill this out and if we could use the items on the caregiver alert thermometer the caregivers were highlighting to then tailor a specific intervention. So we weren't offering the same intervention to every caregiver. We were looking at what they were telling us they needed at an individual level, and we were trying to respond to that as best we could. So what happened is the caregiver would come, they would fill out their measure. We had a clinical nurse specialist who would review the responses and would meet with the caregiver or call them the next day, go through the responses with them, and then would make recommendations or referrals based on the responses as needed. So for example, if they were reporting financial concerns, we might refer them to our social worker. If they were reporting spiritual concerns, we might get our spiritual care providers involved. If they were reporting high levels of emotional distress, then again, we might get some supportive counselling and psychiatrists, psychology involved. So we did this, and then we also conducted qualitative interviews with a subsample of caregivers at the end of the study to really get their feedback on what this meant to them and if it was useful. So this was a pilot study, so we weren't looking at large sample size or a power calculation. It was really just to see, could we recruit participants to this and what would it look like? So we recruited 31 caregivers. You can see that most of them were younger than 65. Well, it was a 50-50 mix between younger and older. Most were female, which is very typical for caregiver interventions. And most of them were the spouse of the patient, and most of them had completed high school or higher education. So we're running into some of the same challenges that I spoke about earlier on when it comes to recruiting participants. We had caregivers of patients with a variety of diagnoses, including GI, head and neck, lung, and breast. What I really want to highlight is the reasons for declining, because this is actually important and I'm going to come back to it later on. So for the vast majority of caregivers, even though they had expressed interest in the study, 38% of them, we were not able to follow up with them by phone to actually get them to participate in the study. And an additional 30% said they were too busy because they were too busy, the patient's health had declined, and they didn't have time to devote themselves to themselves and to focus on their own needs. I apologize. I tried really hard to fix this, but I am not the most technically savvy. So the blue line is the baseline results, and the orange line is what we found at the end of the study. So it's kind of flipped around. On the left-hand side, you can see the different domains of the caregiver alert thermometer. And these were caregiver reports of moderate or high distress at baseline for the blue and at study end for the orange. And just eyeballing that, you can see that caregivers generally had quite high needs about many things at the beginning, about managing their own feelings or worries, about looking after the patient and how their care needs may change over time, about being involved in decision-making or listened to, about financial, legal, or work issues, about balancing their own needs with caregiver duties, excuse the typo, about providing emotional or spiritual care, and who to call in an emergency or out of hours. A broad range of things. And so you can see that for most of these, they actually improved over the course of the study, which was not our primary outcome, but we were definitely really happy to see that. And then at the end of the study, we interviewed 11 caregivers who had participated from start to finish. We really wanted to get their feedback on what they thought of this measure and whether it had been useful for them or not. And so what they reported was, this type of study and being invited to participate, it validated their concerns. So first of all, it added a voice to their needs. And it provided them with some education on how to proceed. So it really validated them being able to speak up for themselves and gave them an opportunity to sort of speak a little bit more freely than they'd previously been able to. As this person said, it gave me an opportunity to voice my concerns and also an opportunity to know that it wasn't an unreasonable request. So a lot of times, this is a caregiver's first foray into caregiving. So they don't know what to expect. They don't know if they're normal or if what they're experiencing is completely unique. And so this person said it gave me the strength and the fortitude to speak up even more. The second theme was navigating a complex healthcare system. So again, our cancer centre, I'm sure it's the very same at in Cork and HSE South-West, it's not the easiest place to navigate. You don't know where to go or what to do or who to ask or what time to be there or where to park your car, or, all of these things, right? So this person said, I emailed ahead of time and I emailed the study nurse and she passed it on. And that was helpful because I think that meant that my oncologist and my palliative care doctor were both aware of the patient issues. And so this patient was having some cognitive issues, but he was really good at kind of hiding it. And so his caregiver was able to reach out in advance, let us know what was going on so that we could be a bit more tuned into it because she didn't feel comfortable to say it in the middle of the visit. And the third theme was around providing resources to prepare for the future. So a lot of times caregivers are not so much worried about now, but worried about what will happen in the future, who to call, where to go, what to do. And as I said at the beginning, sometimes patients aren't really ready or able to have those conversations themselves. And so it's really important, as per caregivers, to have an opportunity to have a side conversation about things like that. So what did we learn from this study? Well, first of all, it showed us that it was feasible to recruit caregivers, that caregivers were really interested in this type of study. They were very enthusiastic about this type of study. And we heard over and over again, I wish this had been offered to me sooner. We had patients who were very enthusiastically volunteering their caregivers and said it's really important that there is something for them, that it's not just all about me. I'm really grateful that you're doing this type of work. Those that participated definitely validated its usefulness and its applicability. So, they really felt that the questions were relevant and that it did apply to them and that it was useful. But we did feel, though, that it was likely perhaps too late in the illness trajectory for many of the caregivers. We heard over and over again, I wish I'd had this sooner. I wish I'd had this at the beginning of my loved one's cancer diagnosis because I had a lot of questions then. Not that I don't have them now, but it would have been even more helpful to me earlier. And we also saw that a lot of caregivers just did not have the time or the ability to commit to this type of project because they were too busy caring for the patient. And so I think that if we had been able to offer it earlier, things may have been different. We had a very heterogeneous group of patients, and recognizing that there may be different caregiver needs depending on the underlying cancer diagnosis. Not every cancer is the same, as we know. So useful, but maybe needs a little bit of tailoring. We found that securing funding for this type of work could be challenging. It may not come as a surprise to anybody on this call that, granting agencies are really interested in funding fancy, expensive cancer drugs. They're not always so enthusiastic about funding caregiver interventions, although they recognize that it's important. It probably comes a little bit lower on the pecking order than some other interventions, and we can debate that, but that was certainly our experience. And we were really lucky that there just happened to be a local granting call that was looking at the human touch of cancer that fit really nicely with this project, but I think it would have been difficult for us at the time to get, funding otherwise. We also experienced very unique considerations when it came to our research and ethics board, which we had not anticipated in advance. Caregivers are not patients. They don't have a hospital record number. And so, there was a lot of back and forth with the REB about, how do we approach caregivers? Do we have to go through the patient to get their consent to then approach the caregiver? What do we do if a caregiver expresses, severe depression or anxiety or something more significant around suicidality? How, liable is the organization to this type of outcome? And there was a lot of back and forth. It actually took an extremely long length of time to get REB approval for this study. I can say much longer than many other studies that maybe would be considered higher risk under normal circumstances. So lots of learning from this. We are not undeterred, however. We are exploring larger studies, two sort of buckets of research that we are now looking into. One is actually working with the individual cancer subspecialty clinics and looking at where there might be highest caregiver needs. So lung, the primary brain tumor clinic, and the pancreas and upper GI clinic, as well as our older adults with cancer clinic. And also we are looking at exploring caregiver interventions nested in an early palliative care intervention for patients with advanced cancer. So a lot of the work that we do at Princess Margaret is around early palliative care for patients with cancer. We're hoping that in a future iteration of this project that we will have a sort of a sub-study that is specifically targeting caregivers using the carer's alert thermometer and the interventions that we described earlier on. So I could talk about this all day, but I'm going to stop right now because I know we got to give the floor to Andy. But if you're interested in learning more, or if you'd like to collaborate, please email me. I would love to chat some more about this.
Breffni, thank you very much for your time. And we'll move quickly on to Andy, and we can return to some questions that I can see coming through in the chat already, Breffni. So thank you very much. Andy, we'll try and get your slides loaded up there for you.
That'll be super. And a couple of shout outs. So firstly to the Cork Cancer Centre for gaining accreditation, European accreditation, really good effort. And then also, of course, it's International Nurses Day today. So congratulations to all our nursing colleagues. So when I think about integrated care, I think about the person at the centre of care. And I think about how we support the person through their peers and their families and their carers, as Breffni was just talking about, and how that needs to be a much more formal aspect of the work that we do and not just left to chance. So I'm really interested in learning more from Breffni. I'm actually here at Maynooth University today talking to colleagues about artificial intelligence, how we can build artificial intelligence into everything that we do. The diagram I would have shown was the Red Bridge diagram, now adopted by Launcher Care, that really demonstrates how we work in an integrated healthcare system in a different way to the way that we might have thought about things. So all parts of the system are important. Cancer is very important to me as REO because I think it's the biggest killer in Ireland. A third to a half of us will have it in our lifetimes. So it's really important to me that we get these services right. If I think about how we're going to do that, the culture of the organisation is very important. And together we've set the purpose of our organisation as being a health services community is proud of. So we want our community to be proud of their cancer services in the same way as they're proud of all the other services that we provide. That's what we want to achieve. And so we've set out some commitments that we think will bring us to that, which are important for cancer carers, for other care. So the commitments are under the 4 HSE values of care, compassion, trust and learning. We've made commitments to patients and patients' colleagues. Under care, the commitment is that we'll value the time of those we are privileged to serve. And that's not just the time between appointments and getting to people quickly, but just valuing their time on earth and making sure that we serve them as best we can with all aspects of their care so that we can make sure that they have good, fulfilling lives. To colleagues, we live our values every day. So it's stressful providing services. And quite often we can find that colleagues can be a bit short with each other. So we do need to make sure that we live the values every day. And I've certainly held myself accountable for living those values. Under compassion for patients, we put ourselves in the shoes of those we are privileged to serve. Very different, very difficult as a professional dealing with people all day, every day, with some of the terrible stories that they provide, to maintain that level of compassion. And then for colleagues, we support each other to be the best that we can be, acknowledging that it's a very difficult job that we're doing. In terms of trust, we're involving those we're privileged to serve as equal partners. Very important that we see people with cancer and their carers as equal partners, and we acknowledge that there's a big power for differential and how we transfer power. In particular, we can think about how we transfer knowledge through some of the resources we have as digital resources. In terms of trust for colleagues, we're saying we're one system, one team, one budget. So we won't be seeking to protect these boundaries around our services or boundaries around our funding. And then in terms of learning, we're going to be looking to avoid harm to patients and staff, working continually to improve our services 7 days a week. So for cancer services, as other services, we're going to be moving very rapidly, actually, in the next few weeks and months to providing services much more 7 days a week. Just move on to the next one if we can. That first slide was the diagram of how we're visioning integrated care, and here's the commitments. And then the last one is just one about governance, accepting at the moment we need to improve our clinical, financial, information, etc. governance. Yeah, so let's come on to the system characteristics. So there's really 6 system characteristics, and I'm going to come on to a little bit more specifically about cancer as part of this. But in terms of a quality service, I'm defining a quality service, really borrowing from the Institute of Medicine's 6 domains of quality, a service that's safe. So we don't want to see cancer patients with neutropenic sepsis. We want to see timely care, so people getting their treatments on time. We want to see what we do to be effective. So there's quite a lot of times when we think maybe some of our treatments aren't particularly effective. They're person-centered around the things that people are looking for us to do, and they're productive. We do need to make sure that we use ourselves and our time as effectively as we can. In terms of value for money in cancer care, we often have to make some difficult choices. We've got some very difficult choices to make as a system now about some particularly expensive drugs for people in the last stages of prostate cancer. And so all the time we're trying to work out the best way to make these choices in cancer care as in everything else. Cost per quality is one way of doing that, one that I favour particularly. So we have to work out, if you're looking at cancer care, do we put our money into maybe very expensive treatments for the last stages of their lives, or do we put it more into prevention? That's the judgments we need to make. I'll talk a bit more about the population health, the health behaviours in terms of cancer care. But clearly, one of the things I need to do is make sure that colleagues on this call have a better experience of work. It is tough being in the health system. I need to make sure we connect better with purpose, we keep people well, really acknowledging that many of our staff will have cancer in their lifetime. And I really pointed to this point about culture. Inequity, we know very well that there are inequities in cancer care and treatment, and we need to address those. I pointed out travelers, people, rurally homeless people. There's a lot of work that shows inequity in outcomes and treatment for people with cancer. And then you might think, what have I put climate sustainability down there for? Well, there's a lot of impacts of the climate on cancer, from exposure to ultraviolet rays, other forms of radiation, to toxic chemicals in our atmosphere, and then just to some of those impacts we see from flooding and other weather events that stop people getting to their treatment. If we could maybe have the last slide. Just in terms then of an integrated health system, so I don't just have an accountability and either as a system for delivering services. It's a population health accountability, and we know that 70 to 80% of our health and well-being derives from health behaviours and socioeconomic factors, and that's certainly true for cancer. So I need to be working on all of these things. I need to be working on housing, education, employment, and that experience of being unwell, maybe with cancer, and having difficulties with your housing or having difficulties in maintaining your jobs. We really need to work on those. Health behaviours, I think we can do an awful lot more on health behaviours. We know the toxic impacts of smoking and alcohol and other things, and what happens to cancer outcomes when there's a lack of exercise. So we really need to work much more as an integrated health system on those health behaviours. Prevention, I think we've done a lot on prevention. We need to do a lot more on prevention. We spend relatively little on prevention and health behaviours, and I'll pledge as RO that we're going to do a lot more. On screening, of course, we have some good screening programs. I think that there are possibly pilot projects on lung cancer, other types of screening. I'm here in Maynooth, and I'm hearing a lot about some of the cancer cells floating around in the body we can detect using AI, so we can do much more. In terms of self-care, we really need to do a lot more to support people in their own wellness and their care, and there are many programs I've been involved in for a large number of years on self-care, so I'll be supporting that. I put down peer support, but following Breffni's talk, that certainly would include carer support. But there's a lot of power in getting better outcomes from peer and carer support we've just heard. Then there's aspects of formal integrated healthcare, so multidisciplinary teams involving the entire care team and the patients. We can talk a bit more about that. Survivorship, of course, many people now, thanks to the efforts of the people on the call, are living with and beyond cancer. And there's many things we can do in terms of survivorship. I was involved in writing the survivorship consensus document for New Zealand, so be really interested in talking to colleagues around that. And then, as Breffni was talking about palliative care, it just reminds me that there's a lot of really good work going on in the cancer there about the use of AI to support palliative care, and I know we can do a lot more to support people at the end of their lives with cancer. So I was going to stop there, a bit of a whistle-stop tour, but I'm sure that people have many questions for Breffni and possibly one or two for me.
Thank you very much, Andy. That was a whistle-stop tour through a very complex web of kind of systems and plans for the future. We have some things coming through in the chat, but I'd encourage people to kind of maybe put in a few more questions or comments. It would really help the conversation from here on in. Breffni, maybe just to start with yourself, there's a question here and it relates to kind of age differences. So just wondering if you are going to look at or have found different needs in carers of older cancer patients, for example, 75 plus, compared to younger cancer patients.
Great question. Thanks so much for that question. We did. We absolutely did. We actually found, and this is borne out in the literature already, that older patients and caregivers tend to be more satisfied, like with the care that is provided to them. Now, there are many reasons why this may be, but we did find that there were some differences between. Sorry, I'm just going to try and get the results to give you the scoop. We did find some differences between older and younger caregivers, that we found older caregivers were more satisfied at baseline compared to younger caregivers. And I think that's probably because, or perhaps one of the reasons for this is because of what I spoke about earlier on, the sort of the life stage that people are at. You know, older, I guess, as an older person, maybe you're more primed for health challenges. You know, you're thinking more along the lines of, you know, our health is going to get worse as we age. Perhaps there are better resources in place for older patients and caregivers through community groups and whatnot. But younger caregivers tend to be generally less satisfied with care that's provided. And I think that's because they're just dealing with a lot more. You know, they're often dealing with their own personal, family, work, financial kind of challenges, and trying to juggle everything at the same time is extremely difficult. But for absolutely certain, I think this is why we're hoping to do a larger study where we will sort of stratify by age of the patient and age of the caregiver, patient-caregiver relationship, to really look at that in a bit more detail.
Great, thank you, Breffni. Andy, one coming through for you now. How are you planning to balance the urgent needs, for example, trolley counts, with the longer term initiative that you've just described there in your talk?
Yeah, so how am I going to resolve some of the urgent things like access to outpatient services, to making sure we've got enough, we don't keep people waiting on trolleys to get into beds? Absolutely. Well, it's really about designing the health system in its entirety. So we are using this healthcare systems engineering approach to redesign the health system. And my view is that we can resolve a lot of those urgent things by putting in some really helpful systems. I'll talk about one of the things that we're doing at the moment. So we're hoping to work with a company called HN, who's currently working, I think, in Kilkenny, that can predict the risk of people coming into the emergency department quite accurately, those who are likely to come in the next 6 months. If we can give those people a program such as Medical Brain, which is like an AI online physician, and connect that in with their GP and also our other community teams, then we can actually prevent people coming into the hospital and care for them at home much more effectively. So I think the initial answer is we're going to use technology much more effectively, particularly AI, or we're going to design systems that both take care of the short-term issues and the longer-term issues, I would say. In terms of longer-term issues, so I'm working on those socioeconomic determinants of health. Even if you go back to things like adverse childhood experiences, ACE is a really good predictor of people's chronic diseases over 50 years. So it's not so much a balance as a both and.
Okay, thanks, Andy. Can I ask you, just from my perspective, you said more kind of digitalization and using technology, and here in palliative care in Cork, we're looking at AI solutions for resource allocation and patient prioritization, and patient reported outcome measures are forming a big part of that. So the patient actually driving their care and their response. Like, obviously that will have to be digitalized, and we're looking at EPROs for the future, I think. And I think there's an EU project, My Path implementation project, that got Horizon funding for that. Like, where do you see that in terms of Ireland, or have you ambitions for electronic PROs and digital platforms to kind of support that?
Yeah, well, unfortunately, Ireland, in Ireland, we're quite a long way behind in terms of digitalisation. I think we're probably the least well digitalised healthcare economy in Europe. So we've got a long way to go. I'm mainly talking about disruptive and transformative ways to about that. So one of the frustrated at the moment by is I'm told it will take us 7 years to get an electronic health record into Cork and Creek. So I'm not going to stand for that. We might have to do some disruptive things to make that happen more quick. But I do have some license around things like AI, where we can use existing digital systems. And we are going to be appointing a regional director of technology and transformation quite soon. And I want that person to concentrate on delivering AI with the existing systems, but also making our system much more ready for digital solutions.
Okay, that sounds exciting and will be very useful. Kate, I see a question here, and it may have relevance for both speakers to an extent, but the question is, with greater integration of the community and the acute setting, is oncology planning happening in the community? And we've been very focused on the setting for oncology. Demand, number, capacity, and need supports and resources in the community support and help our patients and their carers as well in their communities. So speaking to the importance of integrated care, isn't it? And some kind of supports happening out in the community and not being hospital-centric, I suppose.
Is that for me?
Definitely, in terms of, I think it could be for both, but maybe Breffni, in terms of care interventions and community-based care interventions, have your intervention, you bring that out into the community?
I think we're heading in that direction for sure. I mean, it's interesting how no matter where you go in the world, you have these challenges between hospital-based care and community-based care. They really are not always well integrated, and they seem like two unique universes where, you know, there's a lot of lack of communication between home and hospital-based care. I think the beauty of ePros and things like that is you're not waiting for the patient to come to the hospital or the caregiver to come to the hospital to identify these challenges. One of my colleagues is doing some work around remote patient monitoring post-radiation to try and pick up some of those side effects that patients get after radiation, so that rather than waiting and coming back a week later or a month later to the clinic for review, that you're actually picking up in real time through biometrics and wearable technology what's going on with them, and that's, I think, a really exciting way to kind of bridge the gap between the two. In terms of caregivers, you know, there's lots of really great research to show us that if you look after caregivers and you support caregivers, it has positive outcomes for patients in terms of reduces the amount of time they go to the emergency department, facilitates them dying in the preferred place of care. So I think, you know, moving some of those caregiver interventions upstream to earlier in the illness trajectory is undoubtedly going to also improve those patient outcomes later on, when we know patients tend to come to the hospital in those last 3 to 6 months of life. So I think a mixture of both digital and conventional kind of approaches to try and bridge those gaps for sure.
Okay. Just very finally, as kind of you were both curtailed to just 20 minutes on very complex but yet important topics. Any pearls of wisdom that you didn't get time to put into your talk that you'd like to leave the audience with, to be mulling over or contemplating as everyone heads back into their busy work schedules for the afternoon?
I'm going to let Andy take this because I feel like a lot of his time.
Not at all. I think that personalised medicine's got a huge future in cancer, and we really want to know a lot more about it. But it's one of those things where I've spoke about the culture of care, that there's some sociological implications we need to be very mindful of before. That there are things that we can do, but we need to work out whether we should do them.
just because you can doesn't mean you should, I suppose, isn't it? That I was saying. Well, look, on those wise words, we might close out today's session. So this kind of concludes the 2024-2025 Cancer Seminar Series, but the committee will be convening over the course of the summer, putting together another exciting programme for the upcoming academic year. So it's certainly not the last of it. It's just a break for the summer, and I hope everyone has nice plans and has a lot of self-care planned as well. What do they say? Well mother, well baby. So if we're to continue being safe and good practitioners, I think that's also important. And Andy, I'd say you'd support that too. So thumbs up, 2 thumbs up. Thank you both very much for your time. Thanks very much to everyone who attended here during your lunch break as well. We really appreciate it and your engagement. And we will see you after the summer.